also delving into the diseases a little bit too. So, we've got a couple topics, only 3 lectures left in the final test, and then we're done with spring, so that's good. Then on to summer, and summer's pretty straightforward. There's not a lot of material, so that's always nice too. Anyway, so let's get started with this. Depression, there's a bunch of different drugs for depression, but I'll try and streamline it a bit for you here. But we'll talk about the pathophysiology and some kind of interesting facts. So right now on the market, there's about 26 antidepressants available, and these are drugs specifically designed for depression. There's lots of other medications that are used as adjunct therapy for different types of psychiatric illness. So they might have been originally formulated as an antipsychotic, but they're used as adjunct therapy for depression or bipolar. So you get a lot of crossover within psychiatric medicine. So don't be surprised if you have somebody, if you decide to go into psych and you see patients who are on multiple different mixed mechanisms of medications, and the only thing they have on their chart is major depressive disorder or unipolar depression. That's really actually quite common, especially with resistant cases. So as these stats will show you, about 1/3 of patients will experience remission after one round of treatment, meaning one drug, or one period of time at one dose usually. So then, after a subsequent round, either increasing the dose substantially, adding on something as an adjunct, you're going to get 20 to 25% more, and about 30% will have some degree of relapse regardless of what you do. So it's not the best treatment out there, but we can help a lot of people with treatment. Of course, there's other factors at play too, which we'll touch on briefly here. It's a complex disease that's not totally well understood. We know that there's a big serotonin component to it within the central nervous system. And by that, I mean some sort of a deficit in serotonin in certain parts of the brain, because that's how our drugs work. We know that our drugs work on increasing serotonin levels in certain parts of the brain, and we know that that helps depression. So therefore, that must be part of the pathophysiology. However, there's probably a lot more to it than that, as can be seen by a number of other different mixed mechanism drugs that also show benefit in adjunct therapy. There isn't a quick fix, although people are looking for one. And by people I mean researchers. There's no way to just say, okay, you can take this and your depression's going to go away instantly. Whereas like with things like anxiety, we can treat a panic attack and pretty much stop it cold in its tracks with drugs like benzodiazepines. Not the most ideal treatment, but it is a quicker fix. With depression, there's not really a bridge to therapeutic benefit of the drugs. So the drugs take usually 4 weeks is probably more common, and up to even 6 weeks of treatment to really see full effect. So this is the time frame you're looking at of treating a patient with an initial starting dose before you even consider increasing their dose or trying a different drug or adding a drug. Now, there's some literature out there that maybe shows that you could stick on the earlier end. So there's some published literature that shows in small groups of patients that a 2-week trials of antidepressants was adequate for a number of people. However, the bottom line is you have to wait at least a couple of weeks and probably 4 weeks to really test the waters. And we'll talk about some of the kinetics of the different agents too. The ones with much longer half-lives are going to take longer to build up into a steady state into the body's bloodstream, so that will affect that maybe more on the 6-week spectrum, whereas shorter acting drugs that might build up a little bit faster might be a little bit quicker results you could see too. But we'll talk about some of the pathophysiology and what the theory behind this delay in treatment is. I just want to mention this briefly, there was an interesting study done recently that looked at giving people who had pretty severe depression with either suicidal, I can't remember if it was specifically they had a suicidal behavioral incident or just suicidal ideation, but either way, it was serious enough where they wanted something treating now. So they'd give people these IV loading doses of ketamine, which is an anesthetic drug. It's a dissociative agent, an NMDA receptor antagonist, and it actually showed pretty good results. So most of these people didn't have any suicidal ideation afterwards. However, the results were quite short-lived, so most people relapsed into those suicidal ideations within a couple of weeks after the ketamine dose. So that's been an area looking at, well, can you do a sustained ketamine dose? Can you use smaller doses over a brief period of time? Can you give ketamine like in a patch? Can you do it as a more different delivery system? So I think that might be the trick here. It's shown good results so far, but I don't think any clinicians are willing to necessarily stick their neck on the line for it yet. If you do see it, you'll probably see it in research studies or part of trials or as research studies if you happen to work in those types of areas and do psych research. You don't need me to tell you this, but this is a super common disease, highly prevalent, underdiagnosed, probably undertreated. Even for how much depression and antidepressants we prescribe, I think it's probably significantly undertreated. And there's a huge social stigma around depression, right? So it's some sort of a mental fortitude weakness that you take an antidepressant. Well, that's totally bogus. and hopefully as healthcare professionals we can help promote acceptance of mental health disorders, and that really what we're doing is no different than treating something like high blood pressure. So, all right. So what is depression? You'll see. Oops, let me change it on here too. You'll see the two terms kind of interchangeable. Unipolar is the new term, and that's maybe the more PC term, if you're a medically correct term, I should say. Major depression or major depressive disorder was sort of the older term. They call it unipolar to differentiate it from bipolar. And so the definition is you have at least one major depressive episode and have no history of mania or hypomania. That's important. We'll talk about bipolar in the next series of lectures, but that's a big deal because if you treat somebody who has mania or hypomania experiences, they could end up you could end up masking the depressive symptoms, which the patient might enjoy, but then all of a sudden they kind of develop more and more manic episodes, and you can actually kind of precipitate a manic episodes by just treating one side of the illness. So that's a really important part of screening patients who come in depression, especially with people with hypomania. Hypomania is a very mild form of mania, and people actually might enjoy being hypomanic because they might feel like they're accomplishing a lot. They might feel a bit euphoric. Generally, people with hypomania can function well in society. People with full-blown manic episodes usually can't. People with hypomania can kind of ride that line, and they might know that they're in a hypomanic state, but they actually, again, might like it because they're getting stuff done. They feel like they're productive. They feel on top of the world, etc. So it's really important to make sure you're screening patients properly. And that's why bipolar, when we get to there, it's so challenging to treat because most patients who have bipolar might fall into that hypomanic state, and they might really feel like their depressive form of their illness is the one that's driving them into coming to see you or coming to see a provider, and therefore that might be the only real symptoms they focus on. So that's just a side note. But as far as depression goes, these are kind of the symptoms. So 2 weeks, 5 or more of the following symptoms: depressed mood, lack of pleasure, appetite changes, sleep changes, and low energy, poor concentrations. Of course, thoughts of death or suicide would be kind of the paramount thing here, and that would be the major killer of people with depression is suicide. This is just a fun little thing in case you want to know prevalence nationwide of depression. Kind of interesting. Go Minnesota, right? And then just some ethnicity stuff in case you're curious. There's not a whole lot of differences ethnic-wise. Women might be more likely to have higher rates of depression than men. Women tend to be more likely to attempt suicide, men tend to be more successful in their attempts at suicide. They tend to choose more brutal methods like shooting themselves, whereas women might try like an overdose on a pill more commonly, which has variable results depending on what you take. So there's a lot of different statistical stuff, but the bottom line is it affects people of all different ages, all different backgrounds, all different genders. There are some differences here and there, but we really treat everyone pretty much the same. Suicide is in and of itself a huge cause of death among young adults, especially that 18 to 24-year-old. I think it's like the second leading cause of death among teenagers and young adults. So definitely something in that patient population that's worth addressing and worth thinking about. This slide just shows you some stats on costs associated with this. So you've got direct costs, which you can measure, like inpatient hospitalizations, outpatient stuff like that. Some of the other things to think about too is if somebody is struggling with mental illness, and this is about depression, but you could really extrapolate this to any mental illness. The concepts of workplace costs, like absenteeism versus presenteeism. Absenteeism being just missing work because you don't want to come in, or you can't come in because you're in the hospital or whatever. But presenteeism, kind of interesting, being present at work, but maybe just not functioning to the fullest capability that you have. It's just, and of course, this is a bit funny money, and no one really knows exactly what this is. But the point is that there's a lot of, it's a big financial burden on our society, mental illness in general. And the more we can treat it and address it and bring it into the forefront of social acceptability, I think, the more likely people are to seek treatment, and then we can possibly not only help people, but maybe bring down our healthcare costs a little bit as well. All right, so treatment goals. When we treat somebody for depression, we're looking at symptom remission. So it's not completely possible for some patients. Some patients are so treatment resistant that you can really throw the kitchen sink at them. And I'll talk about that very briefly. I mean, this is, you really aren't going to see these patients unless you work with some pretty high acute care psychiatric facility, which I'm not saying none of you guys are going to do, but maybe, anybody interested in psych by any chance? Not a one? Oh, okay. You guys are like, no, just keep moving through this stuff. All right, well, maybe you'll do a rotation and change your mind. Who knows? Anyway, so there can be really advanced cases that are just very difficult to treat. But really what we want to try is to restore their basic functioning. Comorbidities, so death by suicide being the big one. Also general health problems. So people who have depression might neglect other things like their comorbidities, their diabetes, blood pressure management, lifestyle choices that might, cause those diseases to be more pronounced. Substance abuse is, of course, a big one too. With depression, it's there. With other mental health like schizophrenia, much more common with those patients. Patients. So again, both providers and patients need to have some patience with this. And if you don't, your patient is likely to stop therapy. You know, if they take it for a week and like this isn't doing anything, and because no one told them it takes 4 weeks to work. Hopefully somebody would tell them that, but you never know. Just to be upfront with the patient about what the expectations are for some of these medications. Multiple drugs, again, may be required. All right, here's some just Star Wars jokes about a depressed stormtrooper. Here's a depressed cat that was using catnip as a substance abuse problem. So yeah. All right. Okay. So mental health again. I think it's fun to kind of lighten it up a little bit. So hopefully that's not offensive. So selective serotonin reuptake inhibitors, SSRIs, by far and away the most, maybe one of the most common drug classes prescribed in the world, definitely within the United States. So these are first line for major depression, of course. However, you also see them used for all other types of mental illness as well. So when you have a drug for major depression that's so successful, they find that they try it for other things too. So these are first line for generalized anxiety disorder. They're first line for OCD as well. So you can have people who have, you're on if you see somebody on Zoloft or whatever, it might not necessarily mean they have depression. They might have any number of different types of mental illness. Generally speaking, the side effect profile of this drug, I would say, are pretty good. There's not a lot of side effects. We'll talk about the major ones here, and they're all pretty similar per class. There's a couple differences, so that's nice. You don't really have to memorize too many specific ones other than a couple nuances I'm going to tell you about. Minimally toxic and overdose, another great thing. So if you're giving these to people who are potentially suicidal, which is theoretically maybe everyone who has depression, you don't want to give them something that they can easily kill themselves on these drugs. You can take a ton of them and probably not even come close to dying. So it's I've seen plenty of SSRI overdoses. I've never seen anyone have anything more than like some sedation with them. So it's very odd to have any issue. Usually it's some co-ingestant that they have that does it if they're going to die from an overdose. You can switch between agents without retitrating, which is really nice too. So they all essentially do the same thing, and they are people do get varying degrees of success with them. So just because one doesn't work doesn't mean you can't try another one. So if you have max dose of one, you can you can just put them on another similar dose of the other one and see if it works. Most other drugs, like we're going to talk about antipsychotics, most of those you do what's called a cross taper, where you bring one down while you're bringing the other one up at the same time. So this is a little bit different where you can, there is good literature to support just stopping and starting at the same time. And again, patients may respond well to one and poorly to another, so it just depends. The underlying mechanism of how these drugs work is pretty straightforward. So you have two synapses communicating via the neuromolecular transmitter serotonin in this picture here. And so what happens is your body produces serotonin, releases it, and that triggers some sort of a communication pathway between the two neurons. So in this case, maybe reporting a pleasurable mood, since we associate serotonin with that. Well, in the case of excess serotonin, your body has a built-in, what I like to think of as like a recycling pathway. So it pulls serotonin back in and can reuse it that way. And that's what the reuptake inhibition is all about. So this is a process called reuptake. And so our drugs are going to, like you can see here, this little Prozac jelly bean here that they drew, blocks the reuptake pathway. Therefore, you get a higher concentration of serotonin within that synapse. Therefore, more of these receptors can be utilized effectively. And there's a theory that over time, the more serotonin you get in the synapse, the more your body will upregulate new receptors. So maybe it builds a couple more on the side, and then you can even use more and more of it that way. So that's one of the reasons why people think that these drugs take a while to work, is because your body's process in building new receptors is thought to be like a few weeks for it to upregulate all that protein production and make the new receptors in the sites. And so that's, again, a theory. It's not necessarily totally true, but it's a pretty good theory, I think. All right, class-related side effects. Again, most of these apply to all the drugs. GI side effects are sometimes common. Usually people are going to get diarrhea with them. They can be a bit anticholinergic, some of them too, so you might get the opposite. But like, for example, sertraline, which is brand name Zoloft, probably the biggest side effect to remember specifically for that one is diarrhea. It tends to have most, and it's a really commonly used one. So if you start somebody on Zoloft, which is fine, and they come in complaining of loose stools all the time, it might be time to switch them to another one. It's usually a side effect people don't generally enjoy. Sexual dysfunction and decreased libido is really across the board with SSRIs. It's probably their biggest drawback. And when we're looking at it, it does affect both men and women. So I think typically men tend to report this more often than the others than women might, but I think it is important to educate both genders on this. That does affect them. And we'll talk about ways to mitigate this. So the big question is, if somebody's getting a good effect, antidepressant effect from their SSRI, but they're having loss of libido, what do you do? And we can augment therapy, we can change therapy. So we'll talk about very specifically what we're going to do for those patients in a bit. Somnolence, usually these medications don't make people all that sedated. Some people might take them at bedtime, problem solved. But again, they aren't very sedating as a class. Weight gain, not substantial. Some people might experience weight gain because they stopped eating while they were depressed, or their appetite decreased while they were depressed, and so they're feeling like they got their appetite back. They might overdo it. So it could just be a counseling tip if you start somebody on antidepressant treatment to just tell them that that's something to be aware of, especially if that was one of their symptoms of their depression. And bleeding, there's some thought that SSRIs can inhibit platelet aggregation. If you prescribe these to somebody and somebody's on like aspirin, it'll probably flag on their chart and say you're giving somebody a drug that's going to make them bleed out. No one really cares about this in practice. I think it's more of a theoretical concern. I don't think anybody's clinically seen it. But if you're typing in your electronic medical record and that comes up, just know that might happen. As far as anticholinergic, there's kind of a spectrum. Paroxetine is by far the biggest anticholinergic medication. That's Paxil. And I've got another slide kind of highlighting that here in a second. But as far as anticholinergics go, that's really the one to worry about the most is paroxetine. So I'd avoid that in your elderly patients. And generally people are going to have more side effects with that one than any of the other ones. So digging a little deeper, citalopram and S-citalopram. S-citalopram, I don't know if I'd say it's the most common one, but it's one of the most common ones used now. Citalopram was probably the big one. There's Celexa and Lexapro made by the same company. You can tell one's just an S enantiomer of the other, so they're essentially the same thing. And they really are well tolerated. They're once daily medications, so they have about a day worth of a half-life. They're not sedating, they're not activating. And Lexapro or S-citalopram itself really doesn't have any side effects to speak of or drug interactions that are significant. It's a very well tolerated medication, which is why people like prescribing it a lot. It's also generic. Both of these are generic, so go crazy. It's cheap. It's a good drug, and it's oftentimes first line for pretty much everyone in any situation. Now the citalopram itself is still fine, however, it does prolong the QTC interval a little bit. So a while ago, the FDA slapped a whole bunch of warnings on it saying don't prescribe doses over 40 milligrams, and in patients over age 60, you don't want to prescribe over 20 milligrams. It's created a ton of problems because there are probably millions of people who took citalopram every day and maybe took 40 and they were over 60, or they took 60 milligrams, which wasn't an uncommon dose, and were just fine. So all these people, all of a sudden, do you change them or not? So if you do see somebody on a higher dose and they've been stable for a long time, you can always check a QTC, get an EKG on them, but I wouldn't really mess with it. I think it's kind of I think it's an FDA knee-jerk reaction personally. There is some evidence, there's some data looking at citalopram overdoses over time that associated a few cases with heart complications due to the overdose. However, I've seen citalopram overdoses and I've never seen this QTC really prolonged. I've seen some minor prolongation, but not substantially. Where you'd get problems with it is if you're stacking it on top of other QTC prolonging drugs. That's where you'd get concerned. But by itself, it's probably not a huge deal. But S-citalopram doesn't have the extensive QTC prolongation that citalopram does. So it makes Lexapro essentially shielded from that whole controversy. So that's why, again, it's a popular drug. All right, other drugs. So these drugs are all really popular. I don't want to make it sound like people only prescribe Lexapro, because people prescribe all of these. Sertraline, Zoloft, again, GI side effects is probably the only thing I'd remember as far as differences with that drug. Fluoxetine, the big difference, or Prozac, is one of the older SSRIs. The big difference to remember, it's got a 3 to 4 day half-life. So this is the longest half-life of any drug, which means that it might take a bit longer for it to start working. It also might kind of self-taper itself. So if you have somebody who misses like 1 dose a week, fluoxetine might be a great drug to put them on because it's not going to matter if they miss 1 dose a week. Whereas if you put somebody on paroxetine, which is the shortest acting one, they mix 1 dose a week, they're going to feel it. They're going to feel it probably within a few hours of missing that dose. So it's got a really short half-life. I'm going to talk about discontinuation syndrome in a couple slides. They call it, with SSRIs, they call it discontinuation syndrome and not withdrawal because it's got a very specific set of symptoms that appear. But Paxil is also the most anticholinergic. So you get some rebound cholinergic activity, plus you get some other irritability and stuff like that. Paxil is also kind of sedating. You can get paroxetine in a CR formulation, which I believe is generic now. So if you are going to prescribe it, I'd recommend using the extended release. It might help mitigate some of those side effects a little bit, and also prevent people from going into discontinuation syndrome if they happen to miss a dose or get late on a dose. Some other ones, vilazodone, newest agent, not generic, not really worth talking about other than that. It's again, one, when you get these new drugs, you're kind of like, well, what's the point of this? When you have all these other SSRIs that are very popular and seem to work. There's people with resistant treatment. So people end up trying pretty much everything. So if somebody's tried a bunch of SSRIs and nothing's working, well, heck, let's try this one. It's new. Maybe it'll work differently. There's, again, theoretically slight differences with all of these drugs. So you never know. And then fluvoxamine is one that I won't test you on, so don't worry too much about it. It's an old SSRI. This is going to be the only one. This is going to be one of those salvage therapy drugs for people who have tried a lot of things and end up trying fluvoxamine because some people do think there is some evidence maybe pointing towards it being slightly more effective than some of the other ones, but it is an old drug with a bad drug interaction profile and probably has the worst side effects. It's kind of like Paxil, but even worse. Yeah.
Maybe I missed this, but what is the activating?
Activating just means like it's opposite of sedating, so like stimulating. They aren't stimulants, so I don't want to say that per se, but yeah. Okay. So all SSRIs have this black box warning that increases the risk of suicidal thinking and behavior in children, adolescents, and young adults 18 to 24 years old. So it's something to think about. It doesn't mean you can't prescribe them in kids. And I think I had on the other slide, here we go, Paxil. Prozac, was one of the first drugs actually studied in children and one of the ones approved for kids for the youngest age group. So these drugs are studied in kids and have been shown to be generally the benefits would outweigh any risk of this black box warning. However, it is something to consider. Theoretically, people think that when you get an initial increase in serotonin levels in the brain, you might get some sudden burst of energy. So people who are younger and maybe more impulsive might be willing to act on a suicidal plan that they've been thinking about a while, but maybe have been so depressed that they haven't actually had the energy to actually go through with it. Now all of a sudden they're still depressed, but I'm actually motivated to do this, which is of course what we don't want to happen. And they have seen cases of this. So it's not like this happens to everybody. It's quite rare, but it is something worth considering and something to think about when you're educating if you work with this patient population. The flip side of this is this doesn't show any risk in people over 24, and actually people over 65, it has the opposite effect. So there is nice benefit once you get out of that kind of young adult age group. So just, again, closely monitoring for clinical worsening and just being careful. If you have somebody who's really high risk for suicide, might require hospitalization for a couple weeks while you get their medication titrated up. Not uncommon to do that. So better than the alternative for sure. All right, discontinuation syndrome. So I put a ton of symptoms on here. The really thing to think about is basically it's a rebound of a lot of the things people might have been experiencing prior to taking the antidepressant, and it's sudden. So you're going to get you're going to feel really agitated, have anxiety, and depending on what you're being treated for, you might have panic attacks, being really irritable or aggressive, potentially even worsening of mood, dysphoric feeling, just generally not feeling great. It's not going to kill somebody, well, unless they choose to take their life because of it. But this isn't going to physiologically cause somebody to die, but it is very uncomfortable. And of course, the ones that affect GI more, like sertraline potentially and Paxil, paroxetine, could have more of those GI-related symptoms too. But most of them will have a similar presentation to this upon cold turkey. The only one that might be okay would be fluoxetine, but eventually that's going to run out of the system too if you cut it off cold turkey. So people will usually end up with some sort of discomfort off of that too. Best is to taper it off slowly, and I'll talk about that at the end. Serotonin syndrome is something you might hear about too. It's rare, it's deadly, and usually you have to take a lot of different serotonergic agents with these drugs too. So you'll see this as a warning on pretty much every SSRI or any serotonergic thing. I've never actually seen real serotonin syndrome. Well, maybe one case, but that was a drug of abuse, so we don't know for sure. But this is basically you get hyperreflexia, clonus, rigidity, and respiratory failure, along with altered mental status, hypertension, fever, and severe, and that can lead up to severe hyperthermia. So if somebody's usually hypertensive, hot, and they look like they're having some kind of a seizure, and they usually they aren't making any sense, they aren't coherent at all. So that's kind of a serotonin syndrome presentation. Again, it's very, very rare to actually have a documented case of this, but it is something that you'll see as a warning on anything. So just be careful with your serotonergic agents. Okay, any SSRI questions on that before we move on to some other drugs?
Is the sexual dysfunction, is that just when they're on the drug?
Yeah, it should reverse when they're off of it. Mm-hmm.
Yeah, so you don't combine SSRIs?
No.
You'll stop or not stop it abruptly, but change it into try a different SSRI?
Right, you would not combine SSRIs. You could try different SSRIs, or you could add adjuncts. And you generally don't combine SSRIs with SNRIs either, which is this group we're talking about here. They're just too similar. You'd try one or the other. However, I have seen people on both classes. It's just unusual. It wouldn't be a common thing to do, but you could do it theoretically. The problem is you're increasing your risk of that theoretical serotonin syndrome if you try that. But you would never combine two SSRIs. There's no evidence to support it. All right, so SNRIs, as you can see by this drawing here, do the same thing as SSRIs. They just are blocking two different reuptake transporters, so serotonin and norepinephrine. 5-HT being the abbreviation for serotonin, if you didn't know that. Effexor, or venlafaxine, is the oldest drug in this class. It's a really popular antidepressant still. And it's got sort of a dose-related effect of norepinephrine reuptake. So usually at a low dose, it's almost just like an SSRI. It's not all that different. However, the higher the dose you get, the more norepinephrine you get associated with it. So the question you might be having is what's the point? Like, what does it do that's really different? Well, it has a bit of a different profile as far as side effects go. And they think that the norepinephrine might have some sort of an effect on energy levels, maybe restoring people's energy levels more so than just a plain SSRI would do. But if you just look at what we're talking about as far as profile of the drug goes, you can see a little bit of differences. So some things to talk about venlafaxine. It's got a short half-life. So again, I put this as this drug, venlafaxine, and paroxetine would be the two to remember as far as being really careful about not letting people go too long without them, because they both have the highest risk of discontinuation syndrome because they're the shortest half-life agents. And even though venlafaxine comes as an extended release, you still see it. It's still relatively short-acting compared to other medications. And people get the same kind of SSRI type discontinuation syndrome, but they also get these things that I've never experienced this, but I've heard a lot of people talk about this before, and they call them these brain zaps, which are this electric shock-like sensation that they feel in their central nervous system. What exactly that feels like, I don't know, but I've heard a number of people tell me that. I used to do a medication education class for mental health and health outpatients, and I can't tell you how many times people said, "Oh yeah, I accidentally stopped my Effexor. I forgot to take it for a day, and I got the brain zaps." And it's like, it is kind of a documented thing. So, and then also because it is affecting norepinephrine at high doses, you can get some crossover into the peripheral vascular system and central vascular system. So you might get some increase in heart rate, maybe increase in blood pressure, and that can change if you stop the medication. It's usually not a huge deal, but it is possible. They are more dangerous in overdose than a standard SSRI for that reason, because you can get that increased norepinephrine effect, which can cause the cardiovascular issues. And a nice benefit is less sexual dysfunction. So if you have a lot of sexual dysfunction with a number of SSRIs, this is going to be an easy switch for most people to try. Most people find this to be a little bit activating too. So if you're getting sedation on an SSRI, if somebody just feels like they're kind of groggy or out of it throughout the day, this could be a good alternative for them as well. There's another medication called desvenlafaxine, which is called brand name Pristique. It's a newer drug. It's an alternative to this. I'm not aware of any reason to prescribe this other than, again, for people who haven't who have tried a number of other agents and aren't getting good results. They might try that Bristol. Cymbalta or duloxetine is the other drug in this class. It's a good antidepressant on its own, but it's gotten very successful for neuropathic pain, and that's almost probably more use than it as an antidepressant. Not to say you can't use it as an antidepressant, and if you've got somebody who's got diabetes and neuropathic pain, or maybe even osteoarthritic pain, there's some evidence to show that this drug even works for skeletal muscular pain, which is very interesting because it kind of flies in the face of all we know about skeletal muscular pain and how that gets, but maybe how it gets perceived in the central nervous system has something to do with this. But either way, it does seem to work. So if you have somebody with some kind of a chronic pain syndrome, whether it's neuropathic or otherwise, this could be a good drug to try if they also have a mental health disorder. You can, of course, use it on their own. They don't have to have depression to use it for pain. They don't have to have pain for you to use it for depression. It just tends to work for both. And it does have a lot of evidence to support its use in these other markets. Some other things there that I'm not too concerned you know. Effexor, for some reason, there's no reason why you couldn't use it for like neuropathic pain, but it doesn't seem to be as widely used. I'm not sure if it's not studied for that or what, but I think it could have to do with duloxetine maybe having a bit more norepinephrine activity, especially at lower doses than venlafaxine does. These two drugs are kind of newer, milnacipran and levomilnacipran. These are odd drugs, so don't spend too much time on these other than just to know that they're serotonin norepinephrine inhibitors, essentially. And they might have a bit more of the norepinephrine side than the serotonin, so that's kind of their difference. But they do have fibromyalgia indications, so similar to duloxetine. ADRs are quite a bit higher than the other two drugs, so they do have some nausea, dose-dependent headaches, maybe some tachycardia and hypertension because they do work more on that norepinephrine side as well. So again, this is an odd category of drugs, and if you work with a lot of fibromyalgia patients, you might see this used occasionally, probably more so than you would see it actually used as an antidepressant. More of the salvage antidepressant than anything else. And they're pretty much the same, which is why I put them together. Again, one's just an enantiomer of the other. All right, some other useful and common antidepressants. Trazodone. Trazodone is pretty much used as a sleep aid. We'll come back to sleep medications in the next series of lectures. But Trazodone is a really popular sleep aid. It's probably one of the most common ones. It's cheap, it's effective, most people can tolerate it, it's not habit forming. And low doses are quite effective for sedation. However, as an antidepressant, it works, but you have to take a lot more than you do just for the sedative effects. And the more you take, the more sedated you get. So a lot of people can't tolerate enough Trazodone because it carries over too much into the morning and into their daily life. So they just feel groggy, almost like hungover is something people will say they feel like. It is a bit anticholinergic, which can have an effect on that too. So, as an antidepressant, you rarely see it used for that. However, it is theoretically an antidepressant. But don't be surprised if you see this drug on somebody's regimen and they're on other medications like SSRIs. This is one that's combined. It is I don't think I didn't put the mechanism on here, did I? Basically, it blocks some specific serotonin. So it does have some reuptake inhibition, but it also blocks some specific serotonin receptors. So it's a little bit different than your run-of-the-mill SSRI. And it doesn't seem to be all that dangerous when combined with an SSRI, so you see it done quite a bit. But mostly as a sleep aid. So if somebody's SSRI is working well for them, but they're still having issues sleeping, this could be a good drug to try at a low dose and see if that works for them. Orthostatic hypotension in the morning can be something people experience, and it does have a rare but kind of well-documented chance of priapism for men. It's probably less than 0.1%, but it's a counseling tip for anybody. And with how common Trazodone is, it is something that I've seen a number of times. New extended release product. There's a product called Eleptra on the market that's an extended release, supposed to be taken during the day, which is, I don't know why anyone would ever want to take Trazodone during the day, because even so, you'd probably be, even though it's extended release, you're probably still going to be quite sedated. So I don't think this product is taken off all that well.
Can you use this with PRN?
Yes, yeah, Trazodone can be done PRN for sleep, absolutely. All right, Wellbutrin, easily one of the top 5 popular antidepressants. It's got a unique mechanism of action, which makes it kind of on its own island. So you can combine Wellbutrin with pretty much anything. So it's a dopamine reuptake inhibitor for the most part, but it also has maybe some norepinephrine reuptake as well. And It's nice because of a number of reasons. So it doesn't really have the same side effect profile as your SSRIs, and in fact, it's used really commonly as an adjunct to improve sexual dysfunction for people who are getting that side effect from SSRIs. So this is one of the first go-tos people will do if you're getting good antidepressant effects from your SSRI and the patient is having sexual dysfunction or decreased libido. This is one you're going to add on without having to monkey with SSRI dose at all or switch them to a different SSRI. That's a really popular use for it. It does work fine as a standalone antidepressant. There's no reason you can't use it for that, but people just tend to stick to the SSRIs first. It is a bit dangerous in overdose. It can cause seizures. So if you take a whole bunch of bupropion, it can be fatal potentially. So there's that concern with it, which again, SSRIs don't have. However, you do, again, have to take quite a bit. It is something to consider if you have a patient with a history of epilepsy, that it can lower their seizure threshold too. So we've seen that as well with people who start this. So it's a bit of a concern to think about. It tends to wake people up a bit. So if somebody's having issues sleeping, might not be the best drug, or at least keep it in the morning. There's a bunch of different types of bupropion on the market. So there's SRs, XLs, regulars. The history behind this is that the SR was kind of designed as a smoking cessation aid. So bupropion has some other interesting indications, including the ones I've listed here, which all have to do with kind of smoking cessation, gambling addiction, and other addictions, some addictive behaviors, which might make sense if you think about how dopamine is sort of the driving factor behind addiction, or at least one of them. Then this drug can replace that somewhat as far as increasing your neurotransmitters. However, it can also cause people to go the opposite way and increase their impulsivity and actually go on gambling sprees and doesn't work like you would intend it to. So there are some problems with it, but it is approved and studied in some of those areas. Mirtazapine or Remeron is a serotonergic agent with a bit of a different mixed mechanism. So it has some central acting alpha-2 antagonism, so you get which in the central nervous system can cause a roundabout release of serotonin and norepinephrine. It also functions as an antagonist of several serotonin receptors. So you're like, wait, we're talking about drugs that agonize serotonin receptors and antagonize. What am I supposed to remember here? Well, don't remember too many details on this other than know that we're talking about these medications. A lot of times it's like different groups of receptors in different parts of the brain. So mirtazapine might work in a totally different part of the brain than trazodone, but still end up causing sort of a similar effect. So it's all connected in different areas. So you might want to get an overexpression of serotonin in some parts of the brain. It's causing issues. Underexpression in other parts. Used as a sleep aid. So you get paradoxical sedating effect, kind of an interesting drug in the sense that it is more sedating at lower doses. The higher this dose you get, the less sedating it is, but it is an effective antidepressant on its own too. So if you want to use it that way, you can. It's not like it's going to keep people up at night with a higher dose. It's just not going to be quite as effective for sleep. But people do take this in very low dose for sleep aid effectively, kind of like Trazodone. Doesn't cause any sexual dysfunction, which is another reason why people try this medication as an adjunct or switching to it from an SSRI altogether. It also can increase appetite. So if you have somebody who's lost a lot of weight, this could be a good drug. But also think of that as a double-edged sword for your overweight diabetic patient, maybe not the best idea. And then vortioxetine, Trintellix, is a really new drug. It's marketed as a unique drug, but really it's all the same thing. And the only reason I put a whole slide on this is just to point out that these new drugs coming out are really just similar concepts. So we're just talking about manipulating serotonin in a slightly different way. Now, I'm not saying that there's no role in therapy because people very well could respond to this, but essentially it's a serotonin reuptake inhibitor with some different mixed mechanisms of agonism, antagonism within the central nervous system. So it's not really any different than what we've already talked about. Similar side effects to SSRIs, and ultimately, again, it's a new drug, but it's really similar to what we've already got. Yeah.
So all of these ones that we just covered, can you add them on to your SSRIs and SNRIs?
Yeah, I don't think you would add this drug on. You could add bupropion, trazodone, and mirtazapine on. Yep. But this drug is so similar to an SSRI, probably just keep it itself. All right, talking about some older antidepressants, quick. I'm not going to spend a ton of time on these because they aren't all that common anymore. Tricyclics, the big deal with these is they were the first antidepressants that were clinically effective, and they're still quite effective. In fact, there's a study that shows that they're no more that SSRIs, our current generation of them, are no more effective than our older drugs. And in fact, some people might argue that these drugs actually could be more effective. However, they're super deadly in overdose. In fact, I can't think of a drug that's more deadly to overdose on than a tricyclic antidepressant. There's absolutely nothing you can do. The only theoretical treatment you can do for a TCA overdose, if you don't catch it in time and can't like wash it out of the GI tract or bind it up, is give them a whole bunch of lipids and hope that it binds up the drug in their bloodstream. That's really it, and that's very theoretical medicine at best. So these are bad, and they act as an antiarrhythmic in high doses, and it's not good. There's no antidote. There's nothing you can do. So for that reason, people who are taking these drugs therapeutically, when they were using them as antidepressants commonly, were getting 5-7 days at a time, so that they couldn't actually take enough to kill themselves. And that's just inconvenient for everyone, and there's still that risk there too. So anyway, we don't use these a lot for depression anymore. However, neuropathic pain, migraine prophylaxis, and sleep aids, they've all gotten decent use in. So you still see them occasionally. And again, they are effective for depression. So you may see people who have tried things and failed current therapy that's a bit safer, and now are taking these medications. They have a kind of a mixed serotonin norepinephrine reuptake inhibition. So essentially an SNRI with a bit more of a mixed mechanism approach there. They are kind of anticholinergic, antihistaminic, some alpha blocking. So you get orthostatic hypotension, you get all the anticholinergic effects too. So side effect profile is not great, deadly in overdose, makes them not ideal. When people are using them as like a migraine prophylaxis or sleep aids, they're generally taking pretty low doses. So and they're taking them at night. Obviously, if it's a sleep aid, you don't want to take it at night, and then you're getting the benefit of the side effect, right? During the daytime or taking them regularly just might be too much for a lot of people to tolerate all that well. And we talked about MAOIs during Parkinson's, but MAOIs were originally developed for depression, and I kind of touched on this mechanism, but I'll just mention it again. So you're blocking the enzyme responsible, which is monoamine oxidase, and that's going to break down certain neurotransmitters. So monoamine oxidase will break down norepinephrine and serotonin after it undergoes reuptake, and then it gets basically rebuilt into another neurotransmitter. So if you're blocking that, you end up with a lot of extra neurotransmitter available to be used. These drugs are actually highly effective. So I have seen a couple patients on these in my career. It's super rare, so again, I don't want to spend much more time on them than I already am. But they are used as really salvage therapy. So this would kind of be the end of the road. So if you ever see somebody on one of these medications, probably means they've tried everything else under the sun for their depression. They finally found one of these. They work. Super restrictive as far as what kind of foods you can have. What foods? Beer, wine, aged cheese, and meat. Pretty much all my favorite things. So I wouldn't do well on a MAOI. And it has a really high risk for serotonin syndrome. So much so that if you want to put somebody on an MAOI or transfer them off of it, you actually have to undergo a 2-week washout period where they have nothing, which can be highly dangerous for somebody who's at the point where they need one of these medications, probably because they're suicidal. So I've had people in our hospital for months undergoing MAOI transitions because that's really all they have left to try. And I actually seen it work for a couple people, believe it or not. So anyway, if you're more interested, this is just a diagram of how MAOIs work. But again, super rare drugs. Unless you work psych specialty, you're never going to see them. All right, so usually I start with this, but we'll finish with non-pharm options and talk about a couple other little things quickly as far as treatment strategies go. So relaxation techniques have been shown. These are all things that have been studied to a certain extent. Relaxation techniques may help. A lot of these things are like, well, give it a shot. It's worth trying, I think. It might affect somebody. Exercise has been shown to be as effective as drugs for mild cases only. Once you get into severe or moderate depression, not going to be as effective. However, it's a reasonable adjunct. So if somebody's willing to try an exercise regimen, it's probably worth letting them do that. Comorbidities, anxiety, sleep disturbances should be managed appropriately. That can help with the depression as well. As far as supplements go, you have omega-3 supplementation. Probably every person on our psych unit is on omega-3 and vitamin D at any given time. Omega-3 is not really all that well studied. Some people think it has some benefit. There's some mixed reviewed studies out there that have maybe it pointing towards benefit, but ultimately we don't know. However, omega-3s are benign for the most part, so if it's going to help somebody, its risk is extremely low, so you might as well try it, I think is the general theory out there. Vitamin D is very similar. There is a study that showed that vitamin D plus fluoxetine was more effective than fluoxetine plus placebo. So there is some evidence of it being used as an adjunct to current therapy. It's not really any evidence of it being used on its own. And then St. John's wort, we talked about that a little bit. Somewhat effective drug interactions, not standardized dosing, etc. Seasonal affective disorder is SAD, something that people get maybe seasonally. So during the winter, if they aren't exposed to light, light therapy has been prescribed for this. So basically having a big light box with a certain UV wavelength that sort of staring you in the face from an angle. And it hasn't been really studied all that well for standard depression that's not SAD related. So we don't really use it for that. But it could be. Just, again, there's not good evidence for it. And then psychotherapy, should probably be the first thing you think of, but it's a highly recommended thing for pretty much any form of depression. There's countless studies that show that psychotherapy and medication is better than either one by themselves. So I'd highly recommend encouraging people to see a counselor to address some of the issues that they might have. All right, so we talked about duration of treatment, things like that. So short term, again, you're 6 to 12 weeks. You're looking at resolving your symptoms. And you're looking at titrating your dose. So give it a few weeks, at least 4 probably for most drugs, increase your dose. If you get to 6 weeks and they're or 12 weeks and they're at a pretty optimal dose of the SSRI, you probably consider that treatment failure and move on to a different phase. If you do well, you want to continue that for another 6 to 12 months and keep the symptoms in remission. If after 12 months they've been in remission the whole time, you can address what you want to do. So with antidepressants, there's not a lot of guidelines for how long you keep somebody on them. A lot of people take them for life indefinitely, and that's not necessarily wrong. It depends on what they experience. Do they have like kind of a family history of everybody's had mental illness and everybody's had low-grade depression? It doesn't really matter what's happening in their life. It's just there's underlying depression there. Is it because they lost a loved one and it's a temporary thing that maybe they, after a few years they felt better and they can trial off of it? And there's a lot of things you could think about, scenarios that might individualize the patient response. So in that case, the only point of this is saying that you can have somebody on these for life and you can have somebody on them for a couple of years, and there's no real right answer, right specific therapy that's going to work for every single person. I want to talk about the STAR-D trial really quickly. This was a study that looked at a bunch of patients with unipolar depression and combined a whole bunch of medications and put people on this algorithm. I'm not going to test you on this, so don't worry about that. It's a little bit daunting to look at. However, it makes decent sense, I think, if you go through it. So essentially what they did is they started all these people on citalopram, and then they moved people out. So like, let's say somebody started on citalopram, 766 of these patients went on to the next exit. Either they exited the trial for whatever reason, or they moved on to a follow-up period, or they moved on because they didn't have adequate response to these groups here. So what they tried once they tried citalopram was either augmenting citalopram, so you can see they added bupropion. They switched people to several different things, so they switched to bupropion, sertraline, venlafaxine. Buspirone a medication that's a longer-term anti-anxiety. It's kind of a similar serotonergic agent, though, so they use that. They added cognitive therapy here, and they put, or just cognitive therapy alone. So they mixed up a whole bunch of different things, and then they basically moved people through tiers. And you can see the further down you get, you're adding things like tricyclic antidepressants, augmenting with lithium, which is a bipolar medication we're going to talk about next week, and end up with MAOIs at the very bottom of the chart. So this, more or less, while this chart is the STAR, is 2001, so it's a little bit old now. However, it is sort of similar to how we approach treating people for depression currently. So we'll get to some little, I think I've got some little guidelines down here in a minute. But as far as adjunct therapy, so what are you adding on to things? You're going to see a lot of things added on to current SSRI therapy. So beyond Wellbutrin and some of the antidepressants we've talked about, you'll see things like liothyronine. We talked about that with thyroid hormones. So it's a fast onset thyroid hormone supplement thought to help with the depressive symptoms maybe associated with hypothyroid. Mood stabilizers, which are used, either anti-epileptic drugs like valproic acid is a really common adjunct, lamotrigine, and then lithium as well as a mood stabilizer. Antipsychotics is a really popular choice these days, especially the second generation newer antipsychotics. Probably the most popular is one people are going to right away as an adjunct therapy to existing antidepressant. And we'll talk about all those during schizophrenia in the next slide set. And then psychotherapy, of course, should be an adjunct for most people. And then we talked about these. So these are, we aren't really going to talk about general anxiety. Well, we're going to talk about anxiety a little bit more with benzos, but it's pretty much the same approach as you would treat depression. OCD is a very similar approach too. I just want to point that out. So, all right, so what do I want you to know really from a treatment perspective? Well, psych gets a little tricky because it's not as clear-cut as far as these are guidelines, this is what you do. So for mild to moderate depression, evidence would say SSRI plus psychotherapy is probably your best bet right off the bat. And you could combine some of those other like exercise or meditation or whatever techniques you want to try there, that's fine too. But evidence points to that tier being the top. So even if it's a low-dose SSRI and even if it's mild depression, I think psychotherapy is probably worth encouraging or at least bringing up as an option for people. So go 6 to 12 weeks, and this includes optimizing the dose. So remember, 4 weeks, increase dose, try a strategy like that. And then once you get to that 6 to 12 week mark, either that you've tried maybe a starting dose and you're getting some response, so you want to increase the dose, or maybe you're getting nothing at all and you've tried 6 weeks worth and you're like, I don't feel like any more dose of this is going to matter. Or maybe the patient's having, you started them on sertraline and they're having a lot of diarrhea and they don't want to tolerate it anymore. So there's all those, scenarios. But at this point, try another SSRI. Try at least maybe one SSRI. You could switch to an SNRI if they have sexual dysfunction. You can maybe go right to venlafaxine. There's no reason why you can't do that. I kind of think of the venlafaxine and duloxetine as part of the SSRI family as far as where they fall in treatment. They are essentially first-line agents, and they can be used right away. Mirtazapine is a good choice too. Bupropion is a good choice to add on. Again, depending on what side effects a person's experiencing, what things you might want to augment or not. 6 to 12 weeks poor response. You could try looking at thyroid panels. You could do that initially too if you wanted to, but most of the time that probably was done already. Mood stabilizer, antipsychotics are, again, very popular choices right now. Switching to tricyclic antidepressant is not a popular option, even though it's, was maybe more commonly done during the STAR-D trial days. It's really not something we see a lot. Usually we're seeing adjunct antipsychotic mood stabilizer is the more popular choice these days. And then, of course, if you've tried mixing and matching all that stuff in the first 3, you're going to end up with not very many options left. So then you're looking at some of the newer agents, maybe trying some of the newer antidepressants. Ultimately, you could get to things like TCAS, MAOIs, but there's so many combinations of adjuncts out there that it should take a lot of time to be able to get to those really kind of older drugs that we don't see all that much. So we'll talk about adjunct therapy and antipsychotics in the next slide set, so we'll talk about the more popular ones there, but yeah.
You know what the MAOI, like tyrosine, what that combination does, or like reaction does?
It can cause a hypertensive crisis. So you end up with a whole bunch of increased production of norepinephrine, basically.
Okay.
Okay, and switching between agents, this is kind of looks complicated, but basically you're pretty much going to cross taper anything except for SSRIs and SNRIs. You can switch those basically at the equivalent dose. And then you have the MAOIs, which is a 2-week washout. So that's just really the only difference. So I just wanted to point this out because if you work in mental health, this is a super common scenario you run into, and it's worth just having some basic understanding of it. But it's really, I think, quite easy if you just remember SSRIs and SNRIs are essentially equivalent at equivalent doses. Everything else you want to consider cross-tapering. And then SNRIs, if you had somebody on a really high dose of like citalopram and you wanted to start venlafaxine, you might want to consider a cross taper there just to make sure you're doing it correctly. You can't ever go wrong with a cross taper. It just takes a lot more time. It's a lot more inconvenient for the patient. So if you can switch at an equivalent dose, it's a lot easier to do. All right, and just a couple comments about depression and pregnancy quick. So I don't really have a mental health slide for my peripartum stuff, so we'll talk about it now. Pharmacology is usually first line, or pharmacotherapy first line, plus some of the things up here that you could try as well. And, things to consider, prior response, if the patient's already on an SSRI or on an antidepressive regimen, how's that working? Something you could think of. And then as far as things that we like in pregnancy, sertraline and citalopram have probably the most data with pregnancy. Paroxetine may have some risk associated with it that we don't see with sertraline or citalopram, which tend to be quite well tolerated and have really no adverse fetal effect outcomes that we know of. Fluoxetine is avoided because it's got such a long half-life. It's thought that even if it's getting into the fetus at a small amount, it's going to take so long for the fetus to metabolize it. There's possible for increased risk there. And escitalopram is probably fine, but we don't have as much data as with the older drugs. Other options, again, some other drugs have pretty decent data too. Most of the drugs are mostly fine. A lot of them you'll see as category C, so it's a risk-benefit scenario, but tons of people take these during pregnancy with very little issues. So it's generally thought as pretty safe and pretty common practice. Lactation, as far as breastfeeding, so milk excretion, this is really common, especially in your postpartum patient population. So you have looking at what's going to be the lowest amount in the milk, and that's going to be sertraline and paroxetine. So sertraline is a really common drug used for the peripartum patient who is going to be breastfeeding in the postpartum period, because it's well studied during pregnancy, and it's also one of the preferred agents for during breastfeeding because it's got a really low percent excreted into the milk. And most people don't want to switch people to paroxetine. So basically, the moral of the story is there are some guidelines here, but if somebody is doing really well with their current SSRI, probably just keep them on it. So it's not like you have to switch them off citalopram while they're breastfeeding just because the milk expression is a little higher. It's probably going to be fine. It's probably not going to have any adverse effects, but this is the recommended, things to look at. All right, and then stopping your antidepressant. We talked about abrupt discontinuation. Tolerable with some agents, but usually a 2 to 4 week taper is what we're looking at as appropriate. And it depends on how high the dose is, how long the patient's been on it, and what you might consider to be, side effects they might be experiencing. Some patients might want to try a self-taper. I would recommend doing it in a somewhat controlled environment. All right, take a quick 10-minute break. Come back at 1:45.